So we'll keep moving then. So the next section naturally is going to be your intrarenal AKIs. So this is a relatively small proportion of kidney injuries, but it's where a lot of the exam questions come from because it's very specific, minute details. Now, if we went through absolutely all of them in full depth, we would be here for hours and hours and hours, and you wouldn't remember it for the exam. So what I'd rather do is go through the broad groups, talk through some of the key examples, and then give you some resources that you can go away and look at if you'd like to learn more. So the way that I'm dividing the intrarenal pathologies is into glomerular, tubulointerstitial, and vascular. So would anyone like to post in the chat any of the specific intrarenal causes that they know? You don't necessarily have to know which group it falls into, but any intrarenal causes of AKI that you're aware of. Glomerulonephritis, good. There are a lot of potential causes of that, but that is a good group. Acute tubular necrosis we'll come back to because it's a bit debatable. Yeah, IgA, good. Toxicity, yeah. Vasculitis, that's another broad group, so that's good. Acute interstitial nephritis, yeah, that's one of your tubulointerstitial causes, and acute interstitial as well, which we'll go through. Minimal change disease, brilliant, yeah, that's quite, compared to the other intrarenal ones, that's relatively common. Okay, so we'll start moving through them. So you've got a good knowledge of a range of them. This is the section that most people tend to struggle with, and equally you've got the recording of the presentation, so hopefully you can go back through it if you find it useful. Now, the thing that when I first started learning this, I found difficult was to visualize where this is in the kidneys. So I'm doing this more for the benefit of anyone that's quite a visual learner. So you've got the glomerulus, which is the area where the filtration is mainly taking place. So that is your first grouping, things that affect the glomerulus. You've then got things that affect the tubules or the interstitium. So you've got your tubular cells and your interstitium is more like surrounding tissue. And then you've got your vascular causes. So that doesn't refer to the glomerulus specifically, but it's affecting the other blood vessels that are surrounding the kidneys and your supply to your renal parenchyma. So these are the groups that I split it into. So talking about glomerular first, and a lot of these you've already come up with. So you've got autoimmune causes, so things like lupus, Goodpasture syndrome, and IgA nephropathy, which was one that was mentioned. You've got Alport syndrome, which is a hereditary example. There's infective ones, so you've got acute post-strep glomerulonephritis, bacterial endocarditis, and HIV come into that group. There are sclerotic ones. This is a little bit debatable whether it's an etiology or an outcome, but you've got glomerulosclerosis and FSGS in this group. And you've also got your diabetic nephropathy, and then membranous nephropathy and minimal change disease. So for anyone who's done the block, so I know some people have and some people haven't, which ones do you feel out of this group were the ones that were most worth learning? So there's no right or wrong answer here, but which ones did you think are ones that really people need to know about? Cool, so diabetic nephropathy, yeah, definitely, because it's just so common. IgA, minimal change, yep, so there are definitely exam questions that come up on those. Any others that people think are really key? Alport, yep, I agree. Post-strep, FSGS. Good. So that actually aligns perfectly with the ones that I've chosen to go through. So there is a page on Geeky Medics that goes through these in a really nice way. So if you want to read in your own time, I'd recommend that page. So we'll talk about minimal change disease first then. So as you can see from the diagrams, it's really affecting that basement membrane and the area surrounding the glomerulus. So usually this presents as nephrotic syndrome, so proteinuria and hypoalbuminemia plus minus edema. So in children, 75% of cases of minimal change present as nephrotic syndrome, and in adults it's a bit lower. Children are more common to get minimal change disease than adults. Most cases are idiopathic, and the vast majority can be treated with steroids. So in general, minimal change disease is not something we would deem to be that serious compared to other intrarenal pathologies, but it's definitely one that you need to be aware of because it is more common than some of the other causes. So Pathology-wise, you get T cell and cytokine-mediated damage to the basement membrane, which is what we can see in the diagram. And that means that you lose some of your polyanions, which help to provide that barrier. And because you get a reduced electrostatic charge, you then get more albumin passing through the barrier. So you may remember from renal physiology a long time ago that there are two reasons why things can't pass through that barrier. And one is size and one is charge. So really what we're saying here is that there's damage, which leads to a change in the charge of that membrane, which is why more things are passing through. So again, you can definitely read on that in more detail, but that's broadly what's going on in minimal change disease. So the key features are it's often people who don't have hypertension, it's often normotension, proteinuria, which links to the nephrotic syndrome. And the thing that makes it minimal change is on light microscopy, you don't notice any changes, so it's minimal change. But if you look on electron microscopy, you'll see fusion of the podocytes and effacement of the foot processes. So that's the key feature. So if on an exam you were told, amongst other features, so someone presents with proteinuria, they're generally not too unwell, and then on electron microscopy after biopsy, they've got fusion of podocytes, effacement of foot processes, then that's suggesting minimal change disease. I will just take this moment to say, most of these, you're kind of guessing what people have because most people won't have a biopsy. A lot of the intrarenal diseases, you would need a biopsy to absolutely diagnose them, but because we're not doing those on the standard person that comes in, and most things are treated with either steroids or antibiotics, you won't necessarily know for sure if that person had minimal change disease. So you're looking for their key features and what is suggested. Prognosis is good for minimal change disease. So a third of people have just one episode, a third have infrequent relapses, and thinking particularly of children, a third have frequent relapses, but then they stop before they reach adulthood. So you don't really expect them to have that many relapses unless they're in that unfortunate group who do. Right, so that was minimal change disease. Just to check, does anyone have any questions on minimal change disease? Because I know that was a whistle stop and you can definitely read more, but any key questions at this point? No. Okay, so I'll keep going, and the next one that we're going to go through is going to be Goodpasture syndrome. So this is one I would definitely say is worth learning. I think it's one that wasn't mentioned in the chat when we were talking about which ones to learn. But the reason is, again, because there's very easy exam questions on this one. So it is rare, but it's a combination of where you have glomerulonephritis, so kidney injury, and pulmonary hemorrhaging. So you've got someone who's got recurrent hemoptysis alongside blood in their urine, and that's quite a unique combination to like vascular diseases or autoimmune diseases. It's quite an unusual picture. The exact cause isn't known, but it's known that it's to do with where you've got these anti-glomerular basement membrane antibodies, so anti-GBM antibodies against the type 4 collagen around the basement membrane. So again, it's attack of the basement membrane. It is a glomerular condition. Key features, as I've mentioned, you've got hemoptysis, which is unusual compared to the other conditions we're talking about. They might have dyspnea, so challenges with breathing. Equally, you can get that with other kidney injuries though. Fatigue, which can be due to the blood loss. Chest pain, which again could be due to maybe anemia, or it can be due to this pulmonary hemorrhaging itself and or anemia. It's more common in men and it's got a bimodal age distribution. So the key ages are between 20 and 30 and 60 and 70. And it's associated with the HLA-DR2. So a nice little exam question there would be which of the following conditions relates to HLA-DR2, and it would be Goodpasture syndrome. So the thing that really defines this, again, is if you went to the renal biopsy, because you get your linear IgG deposits along the basement membrane. So where you've had your anti-GBM antibodies binding, you've then got those depositing along the basement membrane. And you can get a raised transfer factor secondary to the pulmonary hemorrhages. So someone who's got a raised transfer factor and IgG deposits on the basement membrane, that is pathognomonic of Goodpasture syndrome at that point. There's also a diagram here for anyone who is a bit more visual in their learning. So you can see that you've got a breaking down of the basement membrane and deposits around that area. Okay, so that's Goodpasture syndrome. The next one we're going through, and we're not going through absolutely all of these, by the way, because I know it's very didactic at this point, and there will be a quiz at the end of this section. So the next one is two that are quite similar. So we've got IgA nephropathy, and we've got post-strep glomerulonephritis. Now, this Venn diagram I have pinched from PassMed because it does quite nicely show the difference between the two. So IgA nephropathy, also called Buerger's disease, which was posted in the chat. So this is the commonest cause of glomerulonephritis worldwide, and it's thought to be due to IgA immune complexes depositing. And then again, that's affecting your glomerulus primarily. So the presentation typically is a young male who's got recurrent episodes of visible hematuria. So macroscopic was suggesting that they can see the blood in their urine compared to microscopic, where it's on urine dip. Typically associated with a recent respiratory infection, but it's rare that they've got proteinuria, which is a bit unusual compared to some of the other conditions. And it's unusual to actually get renal failure from this. So you wouldn't really see it as an AKI picture. It's more someone who's got that recurrent hematuria following a recent respiratory infection. There are conditions associated with it, and particularly Henoch-Schönlein purpura. It's quite a similar disease process, so that's the one you want to be particularly aware of it linking with. And on histology, we do have, again, quite specific findings. That's more of a point for memorising. But I want to contrast that with the post-strep glomerulonephritis, because we've just said IgA nephropathy, you've got your recent respiratory infection, and then you've got a kidney injury. Similarly, post-strep glomerulonephritis is you've had a strep infection followed by a kidney injury. So in this case, it's a bit longer after. So rather than it being 1 to 2 days, this is now 7 to 14 days. And it's where you've had a group A beta hemolytic strep infection, and then you're getting immune complex deposition in the glomeruli. So in that sense, it's similar because you've got immune complex deposition. In this case, young children are more commonly affected. So compared to the IgA, which was young males. And the key features here, so you've got very general systemic symptoms, the headache, the malaise. Then you've got your hematuria, the same as IgA, but also proteinuria, which is different. Commonly, you do get hypertension, and then you get a low C3, so complement factor, and raised ASO titer. And there's a nice contrast here in the Venn diagram. So again, I'm aware that I'm throwing a lot of information at you here. But these are two that you really do need to understand the difference, because if in an exam question it's saying somebody has come in, they had a recent respiratory tract infection, you want to know what the time scale was, and you need to know what age that patient is, because those are some of the key things that in an exam setting will help you differentiate between the two. But again, in sort of real life, as long as you can treat them adequately, it doesn't matter massively if you get the diagnosis right. But you know, it's great if you do. And then you've got Alport syndrome. So this was another one that we said was worth knowing, and this is because it is a genetic cause. So it's X-linked dominant. So it's more common in males because males have only one X chromosome. So therefore, because of that, they've got nothing to compensate with. So you've got a defect in the gene that codes for the type 4 collagen. So similar to what we were saying in Goodpastures, where you had that attacking of type 4 collagen, again, it's a problem with the collagen in the basement membrane. A good question here is, why would you have an Alport's patient who's had a renal transplant, but then the renal transplant is failing? And again, it's because you've had that defect in the gene coding for the collagen, and you can almost get a Goodpastures type of picture. They're very similar, but the key thing here is that this is genetic, it's not autoimmune. So it commonly presents in childhood. The key features are microscopic hematuria, so one that you would only really pick up on a dipstick, progressive renal failure, bilateral sensorineural deafness, so that would be one of your key points that you'd want to learn, because that again makes it quite different. Lenticonus, which is protrusion of the lens surface into the anterior chamber of the eye, and retinitis pigmentosa, which if you've not heard of this before, it's worth just having a quick Google of that. So you diagnose it on genetic testing, in addition to, again, if you were to do a renal biopsy, then you would see longitudinal splitting of the lamina densa of the basement membrane. So you get this basket weave appearance. So I keep talking about renal biopsy, but just remember, you're not renal biopsying everyone who comes in with renal injury. It's actually quite rare. You're going to do it more based on the clinical picture. And FSGS, which was one that I mentioned you can argue whether this is an etiology or whether it's an outcome, because there's lots of causes of FSGS is the difference. So this is a cause of nephrotic syndrome. So again, your picture where you've got your proteinuria, your hypoalbuminemia, and possibly edema. And it generally presents in young adults. So the causes vary from idiopathic, which is the most common, to things like HIV and Alport syndrome can also lead to this. And what you would see is that you've got sclerosis, so a thickening, focal and segmental. So you need to be aware of what these terms mean. So it's in a specific area of a specific part within the glomerulus, and you get hyalinosis on light microscopy. So you can actually see this on light microscopy, unlike minimal change disease. But again, like minimal change, you get effacement of the foot processes. Again, similar to with minimal change, you're treating with steroids anyway. So that's why the biopsy doesn't particularly matter. But you might add immunosuppressants in this case. If it's untreated, there's a small chance of it spontaneously going away on its own, but you really would be treating with steroids. And the problem is, if they progress and they end up needing a renal transplant, that's probably not going to solve the problem in this case, because they've got that tendency to develop the scarring within the kidneys, and even in the transplant, they can develop FSGS. So this is one to be aware of. They might not be hugely good candidates for that renal transplant. Right, so at this point, I've been talking for absolutely ages. So we're gonna have a break from me talking, and just to yourselves, I want you to go through and try and answer each of these questions. Once I've given you a couple of minutes to think, then we will go through the answers. But just take a moment, and I'm going to be quiet for a minute. Okay, so I'm hoping you've all had a time to have a look at those questions. So the first question, what is the mode of inheritance for Alport syndrome? So can you just pop in the chat what you think that mode of inheritance is for anyone who remembers? Yep, brilliant, straight away, X-linked dominant. Good, okay. So the next one, which condition most typically presents 1 to 2 days after an upper respiratory tract infection? So which one was that? IgA, yep. Does everyone agree with that? Yeah, we've got good consensus there. As we said, compared to post-strep, which would be 7 to 14 days. Cool. So on biopsy, which of the conditions can be shown to have IgG deposits along the basement membrane? Which one was that? So one person said good pastures. Do people agree or disagree? Got a thumbs up, that suggests agreement. So yeah, that one was good pastures, perfect. What proportion of patients with minimal change disease are successfully managed with steroids? So if you remember, then great. If you don't remember, feel free to take a guess. Okay, So we've had a few 80%, we've had a 1/3, we've had 70, so this was 80%. The 1/3 was referring to how many people don't have a relapse and how many people will have a relapse at some point, but 80% in their episode that they're currently in are successfully treated with steroids, so I hope that's clarified that a bit. And finally, name 3 causes of FSGS. So everyone just post some things that were on that list that you know are causes of FSGS. So HIV, idiopathic, good. Brilliant, yep, got lots of ideas. Yep. Cool, yeah. Yep, and Alport syndrome was as well. Good. So that's a nice summary there of the intrarenal pathologies. So we've currently just covered the glomerular side. There are also the tubulointerstitial and the vascular diseases. So again, I'm going to ask the same question as before. Out of the tubulointerstitial and vascular diseases, which ones do people feel were the most worth learning when they've done the block? If nobody answers, I'm going to assume that you didn't think any of them were worth learning. Okay, we've got hemolytic uremic syndrome. Good, yep, I'd agree with that. Anything else that people thought was worth learning? Yeah, so microangiopathic is, I was thinking the same, but actually it's a feature itself of hemolytic uremic, which is why I'm going to go through just the hemolytic uremic today, but it's worth having a look at. Yeah, interstitial nephritis, that's a good one to look at. Yeah, I think you're right there, Edward. Yeah, okay, cool. So we are going to go through a few of these. Yeah, renal tubular acidosis, I'd agree as well. Okay, so we'll start with renal tubular acidosis. So you get slightly different features depending where it's occurring. So it's depending, if it's more distal, then you're having inability to secrete acidity in the distal tubule. So you're getting hypokalemia. Now that's quite unusual because we said that most renal pathologies cause hyperkalemia. So that's why it's worth noting that renal tubular acidosis can cause low potassium. Therefore, some of the complications with that actually relate to the fact that you're a bit more alkaline, a bit more hypokalemic. So you can get nephrocalcinosis and renal stone development. And some of the causes of that are things like rheumatoid, different autoimmune conditions, and also amphotericin B toxicity. So that's one type. You've then got proximal, so going to sort of the other end here, where you've got reduced bicarbonate reabsorption in the proximal tubule, and that's what causes your hypokalemia. So with both distal and proximal, you're getting hypokalemia, but in the distal, it's because you're not secreting your acid ions, whereas proximal, it's because you've got reduced reabsorption of bicarbonate. Complications for proximal renal tubular acidosis include osteomalacia, and you've got, again, various causes, including things like Fanconi syndrome, Wilson's, outdated tetracyclines, bit niche, but there you go, and carbonic anhydrase inhibitors as well. Okay, and then hyperkalemic. So you can get hyperkalemic renal tubular acidosis. It's not exclusively hypokalemic. And this one, it's just to do with when you've got reduced aldosterone, there's less proximal tubular ammonium excretion, and that causes the high potassium. So given that there's 3 different types here, I think it is going to be quite challenging towards an exam setting for people to remember all of them. But if you just remember, it's a lot more to do with the balance of acid and base, and that you have slightly differing types of this, and the distal and proximal forms, you're more likely to get low potassium. I think if you know that, that's quite a good summary, and there's lots of different causes of all of them. The next one, so acute interstitial nephritis was mentioned as well. So this constitutes 1/4 of drug-induced AKI, so it is worth knowing. and it's worth knowing some of the common causes as well. So the key features of this, you get your features like you're having a drug reaction. So you've got your fever and your rash. People can get an eosinophilia. So your eosinophils are a reaction to allergies as well. And then you can get arthralgia, mild renal impairment, and high blood pressure. So it's all fitting into more of an allergic type of picture, and it's a quarter of the drug-induced AKIs. So common drugs that cause this are things like penicillin, rifampicin, NSAIDs, allopurinol, and furosemide. I dare say there's a lot more on that list. That's just a sample of the ones that can cause it. There's also systemic diseases and infections that can lead to your acute interstitial nephritis as well. The reason I'm going through interstitial nephritis rather than also going through tubulointerstitial is we are just talking about inflammation of these regions, so it's not all that different depending which one you go through. And the general findings, if you're going to look at investigating this, then you're looking for your interstitial edema and your interstitial infiltrates in the connective tissue between the tubules. So because it's the interstitium, you're talking about the surrounding tissue rather than the components themselves. There is this little niche piece where you've got tubulointerstitial nephritis with uveitis. Very random, very unlikely you need to know it, but I just thought I'd chip that in there in case anyone's interested. So that's where you're getting uveitis alongside tubulointerstitial nephritis. Hemolytic uremic. So this is most common in young children. I do think this one is really worth knowing. It's a triad of acute kidney injury, the microangiopathic hemolytic anemia, which we've mentioned, and thrombocytopenia. So it's often secondary, and it's often to do with the E. coli. So when someone's been exposed to the E. coli, that can then lead to hemolytic uremic syndrome. Other causes include pneumococcal infections, HIV. So this is far commonly an infective picture, but quite specific infections. And then you've got rarer causes which are unrelated, and you can have primary HUS, which is far less common. That being said, they're all quite rare, all of these intrarenal pathologies. So to investigate, you'd be thinking about, okay, if someone's got their hemolytic anemia, you want your full blood count, your Us&Es will bring up the fact that they've got an acute kidney injury. And also, if you do a stool culture, you're more likely to pick up the E. coli. So that's why you do a stool culture there. The treatment is supportive in this. Some people do argue for plasma exchange, but it's not applicable in all cases. And there's now a monoclonal antibody that is being introduced, which may be more effective than doing plasma exchange in these patients. Right. So again, that was very brief and I didn't go through everything. So I've just got one quick question here, which again, it is stolen from PassMed. So which of the following is associated with acute interstitial nephritis? So we've got a selection of options there. Just post in the chat which one you think is the answer. So which one of the following is associated with acute interstitial nephritis? And don't worry if you get it wrong, because we're all just learning here. Okay, so a few people have said they think it's penicillin. Good. Good. Okay, you're all absolutely right. It is the penicillin use. So that's why I did go through what the causes were, because that is the kind of thing that can catch people out. Brilliant. So that was a massive section, and that is the biggest section of today's presentation. So the intrarenal AKIs are where a lot of exam questions come from. It's worth just, going through PassMed, going through sites like Geeky Medics, trying to find all those niche details. But it's where you've had an injury within the kidneys themselves, either affecting the glomerulus, the tubules, the interstitium, or the capillaries. And whether you're a rote learner or whether you actually want to really understand those inside and out, I think that's a very personal choice, which is why we've only briefly gone through it. So I've said any final questions on intrarenal AKI. Given how broad it is, I'm more asking, does anyone have quite general things that they don't understand here? Because if it's niche details, I think it's far better that people can go away themselves and learn them. But are there any general questions on this section?